Imagine you engineer a medication to do, one incredibly simple microscopic thing in the human body.
Right. Just one specific job.
Exactly. And it works. But then years later, you find out that this one tiny change is somehow simultaneously helping millions of aging men sleep through the night. It's completely derailing modern cardiology guidelines. And this is the crazy part. It is causing absolute chaos for eye surgeons.
It honestly sounds impossible, right? Like you engineer a tool for one specific job and it just ends up remodeling the entire house.
Welcome to today's deep dive. We are exploring a super fascinating pharmacological story today based on some great source material about a class of drugs called alpha blockers.
Yeah, it's a great topic.
And our mission for you today is to basically trace how this single biological mechanism, which is really just relaxing smooth muscle, ended up solving two wildly different human problems: high blood pressure and blocked urinary flow.
It really is. I mean, it's the ultimate lesson in how interconnected our anatomy actually is. We like to think of the body as this machine with a dedicated button for every single function.
Right, like a neat little control panel.
Exactly. But biology doesn't always build a new button. Often, it just wires the exact same switch into completely different rooms.
And the history of discovering that switch is just an incredible saga. I mean, we're going to get into foundational scientific papers being flat out rejected, massive clinical trials that had to be stopped early just to save lives, and, side effects that literally rewrote surgical checklists.
Yeah, the eye surgery stuff is wild.
It really is. But to understand the real-world drama of these drugs, we kind of have to start small, right? We have to look at the anatomy of a clenched muscle.
We do, and we need to be really specific here because the clench we are talking about isn't like you consciously flexing your bicep at the gym.
Right, not skeletal muscle.
Right, we were talking about smooth muscle. This is the involuntary microscopic muscle tissue that lines the walls of your internal organs, your blood vessels, your bladder. You don't control it.
So alpha blockers, or I guess if we were using the formal medical term from the sources, alpha adrenergic receptor antagonists.
That's the one.
Their entire job is to just float through the bloodstream, find these specific landing pads called alpha receptors on the surface of those smooth muscle cells, and just park themselves right there.
Which fundamentally prevents our body's natural messengers from docking. Specifically, the catecholamine, so epinephrine and norepinephrine, the classic fight-or-flight hormones.
Hold on, let's ground this before we get too deep into the cellular weeds. When norepinephrine normally binds to one of these, like an alpha-1 receptor on a smooth muscle cell, what actually happens?
Okay, yeah.
Because I know the notes mention something called the GQ pathway, but you might need to translate that for me.
Oh, absolutely. Let's break it down. So alpha-1 receptors are G protein-coupled receptors. You can think of them as, well, like a cellular relay station.
Okay.
Normally, a molecule of norepinephrine floats along and binds to the outside of that receptor. And that binding event wakes up an enzyme inside the cell called phospholipase C.
Okay, wait, you just threw an enzyme at me. What does phospholipase C actually do?
So it basically acts like a biological factory. It rapidly generates a secondary messenger molecule called IP3.
So IP3 is basically like the guy running down the hallway yelling at the rest of the cell to do something.
That is actually a great way to look at it.
Yeah.
Yeah, IP3 rushes over to a storage vault inside the cell called the sarcoplasmic reticulum, which is just full of calcium.
Oh, I see where this is going.
Right, so IP3 unlocks the vault, triggering this massive flood of calcium into the main body of the muscle cell.
And if there is one thing I remember from high school biology, it's that when calcium levels spike inside a muscle cell, the muscle contracts. It physically tightens.
It does. Now, imagine this happening in the smooth muscle that wraps around your blood vessels.
Right.
That contraction causes vasoconstriction. The pipes get narrower. And when the pipes get narrower, the pressure of the fluid inside them goes up. So blood pressure rises.
But if someone takes an alpha blocker, that drug gets to the receptor first, and it just sits there. It's like norepinephrine is trying to send a clenched text message to the muscle cell, but the alpha blocker has snuck in and changed the Wi-Fi password.
I love that analogy.
The message just never goes through. The enzyme never wakes up. The calcium vault stays locked.
And because the calcium stays locked away, the smooth muscle has absolutely no choice but to relax. The blood vessel widens and blood pressure drops. But, the geography of where this happens is what makes this drug class so fascinating.
Because of the different rooms, like you said earlier.
Yes, because that exact same Wi-Fi network, that alpha-1 receptor, doesn't just exist in your blood vessels. It is heavily concentrated in the smooth muscle at the neck of the bladder and wrapped all around the prostate.
Meaning if you block the receptor there, you loosen the muscular ring around the urinary outlet, the pipes open up.
Precisely.
So it's the exact same molecular mechanism, but because the receptor is located in two completely different geographical areas of the body, you get two totally different clinical payoffs: lower blood pressure or easier urination.
Yeah. Though before we move on, we really have to address a massive point of confusion here.
Oh, I think I know what you're going to say.
Well, when people hear about a drug that lowers blood pressure by blocking adrenaline, they immediately think of the heart.
Right. People confuse alpha blockers with beta blockers.
It happens all the time, honestly, even in medical training. Beta blockers primarily target beta-1 receptors, which are physically located in the heart tissue itself.
Mm-hmm.
They literally slow the heart rate down and reduce how forcefully the heart pumps. Alpha blockers absolutely do not do that.
They don't touch the heart at all.
They do not touch the heart's internal pacemaker. Their primary site of action is always the smooth muscle in the periphery, so the blood vessels or the urinary tract.
Wait, but I know people who take alpha blockers and they've complained about their heart racing. Like, if the drug doesn't touch the heart, why is that happening?
Because the body's panicking. Yeah. When an alpha blocker suddenly widens the blood vessels, blood pressure drops rapidly. The brain senses that drop and thinks, uh-oh, we're losing pressure, we need to compensate right now.
Oh, so it kicks into overdrive.
Exactly. It sends an emergency signal to the heart to beat faster just to keep the blood flowing. It is a secondary reflex response. The heart is reacting to the sudden drop in pressure, not to the drug itself.
That distinction makes a lot of sense. But, I mean, figuring out that there were different receptors and different organs in the first place, that was not an easy process, was it? Like, in the 1940s, doctors were essentially operating in the dark.
They were completely baffled. I mean, they knew about catecholamines like adrenaline, but when they injected them into animals, the effects were just chaotic.
Like, completely unpredictable.
Yeah. In some tissues, adrenaline constricted blood vessels. But in a different organ, it dilated them. It sped up the heart, but it relaxed the intestines.
So confusing.
Right. No single theory could explain why one molecule could cause completely opposite reactions.
Until this pharmacologist named Raymond Alquist comes along in 1948 and does this brilliant, honestly, painfully tedious experiment.
Yeah, Alquist decided to test a whole lineup of different adrenaline-like drugs across a huge variety of animal tissues. Dog intestines, rabbit blood vessels, cat hearts. He just systematically measured how strongly each tissue reacted to each specific drug.
And he finally found a pattern.
2 patterns, to be exact. The tissues cleanly split into 2 distinct rank orders of potency. One group of tissues responded best to one specific chemical structure, and the other group responded to a different one.
So he hypothesized that there must be 2 entirely different types of receptors receiving the signals.
Right, and he named them alpha and beta.
He essentially invents modern cardiovascular pharmacology with this. And yet, according to the sources, his paper, what was it called? A Study of the Adrenotropic Receptors, was rejected by peer review. The Journal of Pharmacology and Experimental Therapeutics literally turned it down.
Flat out rejected. It was too radical for them. It challenged the prevailing dogma that there was only one type of receptor.
Wow.
Eventually, he got it published in the American Journal of Physiology, and, it changed the entire field. But even Alquist's groundbreaking alpha-beta split wasn't the end of the story.
No, because within the alpha category, there was this hidden division that caused early doctors a lot of grief.
Yes. You're talking about alpha-1 versus alpha-2.
Exactly.
So alpha-1 is the receptor we've been talking about, the one on the smooth muscle that causes the clench. But alpha-2 is entirely different. Alpha-2 receptors don't sit on the muscle.
Where are they?
They sit presynaptically, meaning they are located on the nerve terminals themselves, the parts of the neuron that release the norepinephrine in the first place.
So what are they doing way up there?
They act as a negative feedback loop, basically a brake pedal. When a neuron releases norepinephrine into the gap to trigger the muscle, some of that norepinephrine drifts backward and binds to the alpha-2 receptor on the neuron itself.
Oh.
It's a signal that basically says, okay, message received, we have enough adrenaline in the gap, you can stop releasing more.
Ah, I see the problem. If you design a drug to block alpha receptors and it isn't picky about which one it hits.
You get the sledgehammer drugs of the 1950s.
Right.
Drugs like phenoxybenzamine. They blocked alpha-1, which successfully relaxed the blood vessels, but they also indiscriminately blocked alpha-2.
So by blocking alpha-2, you are effectively cutting the brake lines while the car is going downhill. The neuron never gets the message to stop.
Exactly. It just keeps pumping out massive amounts of norepinephrine. So you flood the system with adrenaline, which totally undercuts the relaxation effect you wanted in the first place.
Oh, man.
And this caused patients to suffer from severe reflex tachycardia, a violently racing heart and terrible palpitations.
That sounds like a horrible experience for a patient who is just trying to manage their blood pressure.
It was awful, which is why those non-selective sledgehammers are almost never used for routine hypertension today. However, there is one very specific, dramatic scenario where doctors actively want to use that sledgehammer effect.
Right, the pheochromocytoma.
Yes. A pheochromocytoma is a rare, super dangerous tumor that grows in the adrenal gland. And this tumor essentially goes rogue, secreting massive, unpredictable surges of adrenaline directly into the bloodstream.
I can imagine how dangerous that is for a surgeon if they go in to cut that tumor out. Just physically manipulating it with surgical instruments could squeeze a lethal storm of adrenaline into the patient's body, triggering a hypertensive crisis right on the operating table.
Exactly. So to prevent that, anesthesiologists will pre-treat the patient with phenoxybenzamine for about 10 to 14 days before the surgery.
Okay.
And they use phenoxybenzamine specifically because it doesn't just temporarily block the alpha receptors, it binds to them covalently. It permanently caps them off.
Wait, like it destroys the receptor. How does a
Ah.
patient survive if their blood pressure receptors are permanently shut down?
Well, the body is constantly recycling and synthesizing new proteins. So over the course of several days, the cells will eventually build brand new, unblocked receptors to replace the ruined ones.
Oh, I see.
But by permanently capping the existing receptors right before surgery, you guarantee that even if that tumor dumps a tidal wave of adrenaline during the operation, the hormone has absolutely nowhere to dock. The patient is shielded.
That is wild. It's like boarding up all the windows of a house before a hurricane.
It really is.
But again, for everyday patients who just needed their blood pressure lowered, the sledgehammer was just too brutal, which kicked off this era of precision engineering in the 1970s.
Right, so Pfizer stepped up and developed a drug called prazosin. This was a massive triumph of rational drug design. They built a molecule that selectively targeted only the alpha-1 receptor, leaving the alpha-2 brake pedal completely untouched.
Which solved the runaway adrenaline problem.
It did.
But prazosin came with its own notorious clinical hazard, right? The first dose phenomenon.
Yes, profound orthostatic hypotension,
Meaning they pass out.
basically. When a patient takes their very first dose of prazosin, or if their doctor increases the dose, the drug aggressively dilates the blood vessels. Now, normally when you stand up from a chair, gravity pulls your blood down, and your blood vessels instantly constrict a little bit to push blood back up to your brain.
But if those vessels are blocked by prazosin, they can't constrict.
They stay wide open, blood pools in the legs, blood pressure plummets, and the patient can literally faint and collapse the very first time they stand up.
Which is why the classic medical advice is to always take that first dose at bedtime. You take it, you lie down, and you just sleep through the cardiovascular chaos while your body's baroreceptors recalibrate to this new normal.
Exactly. It's a reminder that even when a drug is incredibly precise on a molecular level, it can still cause massive systemic shifts.
Yeah.
But medicinal chemists weren't done. By the 1990s, the technology to clone and map receptors improved dramatically. And they discovered that alpha-1 wasn't just a single target either.
Right, there were subtypes.
Exactly. They mapped out several subtypes, but the two most important for our story are alpha-1A and alpha-1B. They found that alpha-1B receptors were highly concentrated in the blood vessels,
Okay.
but alpha-1A receptors were densely packed in the prostate and the neck of the bladder.
And this is where a pharmaceutical company called Yamanouchi strikes gold in the late 90s. They engineer tamsulosin, a drug that is highly uroselective. It heavily targets the alpha-1A receptors in the prostate while mostly ignoring the alpha-1B receptors in the blood vessels.
This completely revolutionized the treatment of benign prostatic hyperplasia, or BPH.
Right.
Because, as men age, the prostate gland naturally enlarges, which physically pinches the urethra.
Right.
But it also increases the resting smooth muscle tone in that area, creating this tight, restrictive grip.
Which leads to those terrible quality of life issues, hesitancy, weak urinary stream, waking up 4 or 5 times a night to go to the bathroom.
Yeah. Tamsulosin selectively relaxes that specific prostatic smooth muscle. It loosens the grip around the urethra, restoring normal urine flow.
And the beauty of the uroselectivity is that because it leaves the blood vessels alone, you don't drop the patient's blood pressure. Like, a man with completely normal blood pressure can take tamsulosin for his prostate and not faint when he stands up out of bed.
It really is the pinnacle of refining a drug to avoid side effects.
I want to pause here for a second because if you're listening right now and you or like a family member are looking at a prescription bottle for an enlarged prostate, you might be taking an alpha blocker, or you might be taking something called a 5-alpha reductase inhibitor like finasteride.
Right, very common.
And since they both have the word alpha in the name and they both treat BPH, it's so easy to assume they do the exact same thing.
It is one of the most common mix-ups, but their mechanics couldn't be more different. Tamsulosin, the alpha blocker, provides very fast symptom relief, often within just a few days.
Wow, that fast.
Yeah, because it does this purely by relaxing the existing muscle tissue. It does not change the actual physical size of the prostate gland.
It just loosens the corset.
Precisely. Finasteride, on the other hand, the 5-alpha reductase inhibitor, attacks the hormonal root of the problem. It blocks the enzyme that converts testosterone into dihydrotestosterone, which is the hormone that makes the prostate grow in the first place.
So finasteride physically shrinks the enlarged gland over time.
It does. But that shrinking process takes months to show clinical results.
Which completely explains why a doctor might prescribe both at the same time. You know, tamsulosin for rapid relief today, and finasteride to shrink the gland for the long term.
Exactly, the perfect complementary strategy.
So by the late 1990s, medicine had seemingly perfected this class of drugs. We had tamsulosin for the prostate, and we had highly selective alpha-1 blockers like doxazosin to treat high blood pressure.
Right.
The drugs worked beautifully. They lowered the numbers on the blood pressure monitor reliably. The science felt completely settled. And then the ALHAT trial happened.
Oh, man. This is the central controversy of the field. So ALHAT stands for the Antihypertensive and Lipid-Lowering Treatment to Prevent Heart Attack trial.
Quite a mouthful.
Very. It was this massive landmark government-funded study involving over 40,000 participants. They wanted to see which class of blood pressure medication actually prevented heart attacks and strokes best in the real world.
Right, so they pitted doxazosin, the highly selective alpha blocker, against chlorthalidone, which is just a standard cheap diuretic or water pill.
And in the year 2000, an independent safety committee reviewing the early data abruptly halted the doxazosin arm of the trial.
Halted it, like completely stopped it. Why?
Because the patients taking the alpha blocker had roughly double the rate of combined cardiovascular events compared to the diuretic group.
Double?
Yes. And what was driving that terrifying statistic was a significantly higher rate of new-onset heart failure.
Wait, I'm struggling to understand the physics of that. If the alpha blocker is successfully widening the pipes, which lowers the pressure, shouldn't the heart be working, like, less hard? How does that lead to heart failure?
It seems so counterintuitive, but it comes back to how thorough the drug is. Alpha-1 blockers don't just dilate your arteries, which carry high-pressure blood away from the heart. They also dilate your veins, which carry low-pressure blood back to the heart.
And veins are very stretched.
Extremely stretchy. So when you forcibly dilate the veins, blood tends to pool in the lower extremities due to gravity. The heart suddenly isn't getting as much blood returned to it.
Oh, wow.
Yeah. And the body senses this venous pooling and thinks it's dehydrated, so the kidneys start retaining sodium and fluid to pump up the blood volume.
Ah, fluid retention.
Right. And over months and years, that chronic fluid retention puts massive strain on the heart, worsening occult or hidden heart failure. Combine that with the fact that the diuretic they were competing against actively removes fluid from the body, and the alpha blocker just looked terrible by comparison.
It's such a sobering lesson for modern medicine, you know? Doxazosin did exactly what it was engineered to do mechanically. It lowered the number on the blood pressure cuff, but it was actively failing the patient.
It exposes the profound danger of relying purely on surrogate endpoints. A surrogate endpoint, like a blood pressure reading or a cholesterol number, is super easy to measure in a clinic. But the hard endpoints are what actually matter to a human being. Did you prevent the heart attack? Did you keep them out of the hospital?
And because doxazosin failed the hard endpoint, the guidelines were rewritten. Alpha blockers were aggressively demoted.
Yeah, they are practically never recommended as a first-line therapy for basic high blood pressure anymore. They're still used, but usually as a third or fourth option when nothing else works.
Just because a drug's mechanism makes logical, elegant sense on a whiteboard does not guarantee it will produce better long-term clinical outcomes in a complex human body.
Exactly right.
So the ALHAT trial proved that highly targeted drugs can have deeply unexpected consequences for the cardiovascular system. But the most bizarre consequence of this drug class actually happened in an organ system literally no one saw coming. Yes, So set the stage for me here. Because BPH affects a huge percentage of the aging population, tamsulosin is one of the most widely prescribed drugs on Earth.
The statistics are honestly staggering. Over half of men in their 60s and a substantial majority in their 80s experience BPH symptoms. Millions of people take tamsulosin daily. It restores their ability to sleep and function.
But around 2005, ophthalmologists started noticing something incredibly strange and terrifying happening during routine cataract surgeries.
They documented a phenomenon that they eventually named intraoperative floppy iris syndrome, or IFS.
Right, and during a cataract surgery, the surgeon needs to remove the cloudy lens of the eye and insert a clear artificial one. To do that safely, the iris, the colored part of your eye, needs to be fully dilated and totally rigid.
But in certain patients, the iris would suddenly lose all its muscle tone. It would become floppy. It would billow around in the fluid of the eye and even prolapse out of the microscopic surgical incisions.
That sounds terrifying.
It made a routine surgery incredibly difficult and severely raised the risk of tearing the tissue or even blinding the patient.
And when researchers dug into the medical histories of these patients, they found a single common thread: tamsulosin. Why? Because the muscle that pulls your iris open, the iris dilator muscle, is composed of smooth muscle.
And what does that specific smooth muscle rely on to maintain its structure and tone? Alpha-1 receptors.
It's crazy. You engineer a drug specifically to target the prostate, but because it goes after smooth muscle, it ends up hijacking the muscle that controls your pupil.
Yep.
But what's truly wild to me is that the risk of this floppy iris syndrome persists even years after a patient stops taking tamsulosin.
That is definitely the most concerning part. The drug doesn't just temporarily block the receptor. Long-term use actually appears to cause structural atrophy in the iris dilator muscle itself. The muscle literally loses its physical strength.
Oh.
So the risk doesn't vanish just because the drug washes out of your bloodstream.
Which completely changed how eye doctors operate. Today, across all of ophthalmology, it is a mandatory bold print question on the intake forms before any eye surgery. Are you taking, or have you ever taken, tamsulosin?
A prostate medication fundamentally altered the standard operating procedures of eye surgeons around the world. It's just a brilliant, humbling reminder that the body repurposes its cellular building blocks absolutely everywhere.
It really is. Okay, let's look back at the incredible journey we've mapped out today. So it started with one microscopic mechanism stopping the GQ pathway to keep calcium out of a cell and relax smooth muscle.
Right.
That single switch gave us two massive clinical breakthroughs: widening blood vessels to drop pressure and loosening the prostate to ease urine flow.
We followed Raymond Ahlquist, whose foundational discovery of alpha and beta receptors was initially rejected by the scientific establishment.
We looked at the extreme sledgehammer approach of phenoxybenzamine, permanently capping receptors to help patients survive terrifying adrenal tumors. We saw the triumph of engineering with tamsulosin, targeting just the alpha-1A subtypes in the prostate.
And we got a brutal reality check from the ALHAT trial, proving that good blood pressure numbers don't always mean a healthy heart.
And finally, the bizarre crossover of floppy iris syndrome.
It is a perfect encapsulation of pharmacology. Every single intervention is a negotiation with a highly complex, interconnected system.
Which leaves me with a lingering thought that I really want you, the listener, to mull over. Knowing that smooth muscle is woven into the architecture of almost every organ system we possess, from our blood vessels to our bladders, our intestines, and even our eyes. It makes you wonder, what other invisible side effects are our highly targeted modern medications quietly having in the background, simply because the human body is using the exact same biological Wi-Fi network in a dozen different rooms.
When you intervene in biology, you are never just doing one thing.
Thank you so much for joining us on this deep dive into the sources today. We hope this gave you a whole new appreciation for the complex plumbing of the human body. Have a great day of learning.